will be the first to present his work.
Good morning, everyone, and thank you all for being here. On behalf of my co-investigators, I'd like to thank the organizing committee for giving us this opportunity to share with you this morning clinical results from a phase 1 trial of PRT3789, a first-in-class intravenous SMARCA2 degrader in patients with advanced solid tumors with a SMARCA4 mutation. These are my conflicts of interest. The tumor suppressor SMARCA4 is inactivated in a variety of different cancers, including non-small cell lung cancer, where SMARCA4 mutations are observed in approximately 10% of cases, and importantly are associated with more aggressive and invasive disease and poor clinical outcomes. There are currently no available therapies that target SMARCA4 deficient cancers in the clinic. However, we know that SMARCA4 mutated cancers become reliant on SMARCA2, and selectively degrading SMARCA2 offers an attractive approach to induce synthetic lethality in SMARCA4 mutant tumors. PRT3789 is an intravenous SMARCA2 degrader that is highly potent and selective for SMARCA2 over SMARCA4, and importantly induces synthetic lethality in various CDX and PDX mouse models of SMARCA4 deficient cancer at well-tolerated doses as shown in this graph. This is our study schema and patient enrollment to date with PRT3789 monotherapy, which comprises dose escalation cohorts and also backfill cohorts. Eligibility criteria included any patient with an advanced solid tumor with any SMARCA4 mutations, including both class 1 and class 2 alterations, patients with evaluable disease are eligible for the trial as well. PRT3789 is given weekly, intravenously, and we started at a dose of 24 milligrams weekly of 3789 and are currently dose escalating at 665 milligrams as shown in this figure. We've also been undertaking backfill cohorts as shown in this slide, and the eligibility for the backfill cohorts included an enrichment for patients with non-small cell lung cancer harboring loss of function SMARCA4 mutations with measurable disease in these patients as well. Here are the patient demographics with 3789 monotherapy. We've recruited 65 patients in total, median age 62 years. There were more males than females. This was a heavily pretreated patient population with a median of 3 prior lines of systemic therapy. Most common tumor types included non-small cell lung cancer, followed by pancreas and breast cancer. There were more class 1 SMARCA4 mutations included versus class 2 alterations, which included missense and variants of unknown significance. 7 patients were enrolled based on loss of SMARCA4 protein by IHC. Here is a summary of the adverse events with PRT3789 monotherapy. This drug was very well tolerated. In terms of grade 3 or worse adverse events, there were only 5 patients who had treatment-related AEs that were grade 3 or greater. No patients actually had treatment-related SAEs. Only 4 patients had treatment-related adverse events leading to drug hold. 2 patients had adverse events leading to dose reduction, and only 4 patients had adverse events leading to treatment discontinuation. And importantly, there were no dose-limiting toxicities observed to date. The most frequent adverse events included nausea, fatigue, and anemia. Here's the anti-tumor activity in this waterfall plot. You can see that we saw partial responses in multiple patients, including non-small cell lung cancer and esophageal cancer across different doses. And these were all seen in patients with class 1 SMARCA4 mutations. Here is a swimmer plot showing the duration of treatment in patients with non-small cell lung cancer or esophageal cancer. You can see we did observe durable stability of disease and also responses, including a patient out at approximately 61 weeks. Here is a response rate in non-small cell lung cancer or esophageal cancer. in patients who are evaluable for efficacy in patients with class 1 mutations. And at a biologically effective dose of 283 milligrams of PRT-3789, the objective response rate was 22%, and 33% of patients also had durable, stable disease. Here are some examples of responses in patients with non-small cell lung cancer. On the left-hand side, you'll see CT scans from a patient who was a 72-year-old man with metastatic polydifferentiated carcinoma of the lung with squamous differentiation. The patient had a SMARCA4 splice site alteration, had previously received chemotherapy and also chemo-IO, followed by disease progression. The patient was enrolled at a dose of 283 milligrams weekly of 3789 and achieved a RECIST partial response on a second follow-up scan with a reduction in liver and adrenal lesions as well as lymph nodes. On the right, you'll see a patient who is a 72-year-old man with moderately well-differentiated lung adenocarcinoma. At baseline, this patient had brain metastases and malignant pleural effusion and ascites. This was a patient who had a SMARCA4 splice variant, who had previously received chemotherapy and chemo-IO as well, followed by progression. He was also treated at a dose of 283 milligrams weekly of 3789 and achieved a partial response by RECIST criteria on his first follow-up scan with reduction in lung lesions, lymph nodes, pelvic lesions, and also full resolution of ascites as shown in the scans on the top. Here's an example of the responses that we observed in esophageal cancer. This is a 53-year-old man with metastatic polydifferentiated carcinoma of the esophagus with squamous differentiation. This patient had SMARCA4 deletions and frameshift alterations, previously received chemotherapy and IO, followed by disease progression. This patient was treated at 24 milligrams weekly of 3789 and achieved a RECIST partial response on his first follow-up scan with a reduction in liver and adrenal lesions and also lymph nodes, as shown in the figures on the right. Here are the PK and PD data confirming target engagement by SMARCA2 reduction. On the left, you'll see increasing median concentrations of PRT-3789 with increasing doses of drug. We observed that the pharmacodynamic effects were more prolonged than pharmacokinetics. And importantly, increasing doses show deeper and more prolonged pharmacodynamic effects on SMARCA2 levels in peripheral blood mononuclear cells, as shown in this figure, by increasing doses of drug. We also observed target engagement that was confirmed by SMARCA2 reduction in tumor tissue. And I show here paired tumor biopsies from a 42-year-old male with large cell neuroendocrine cancer. This patient was treated on our combination cohort of docetaxel plus 120 milligrams of PRT-3789. And in these figures here, you see an 88% decrease in SMARCA2 expression on cycle 2, day 3, 2 days post-dose. And in this figure here, you see a shift in the cells from high-intensity SMARCA2 staining in baseline tumor to weak or absent staining in his on-treatment tumor biopsy. And we also observed, importantly, changes in PBMC SMARCA2 levels from pre-dose levels. You can see here SMARCA2 levels in PBMC showed a 65% degradation on cycle 2, day 1 pre-dose relative to baseline levels, suggesting sustained SMARCA2 decreases over time. I show here on this slide the distribution of the SMARCA4 mutations in all study patients. And you'll see that the SMARCA4 mutations occur across the length of the gene. We observe class 1 alterations comprising truncation, frameshift, and splice site variants, and also class 2 variants, including missense variants, as well as variants of unknown significance. I show on this slide the types of SMARCA4 mutations and co-mutations in class 1 lung and esophageal study patients. And you see that with the class 1 SMARCA4 mutations, these comprise 42% truncation alterations, 32% frameshifts, 13% splice site variants, and 3% deleterious alterations. The most common co-mutations included TP53, followed by CDKN2A, KEAP1, KRAS, and STK11 alterations. Now moving on to our combination with docetaxel, with PRT3789. Again, this comprises dose escalation cohorts and also backfill cohorts. Eligibility criteria was similar to our monotherapy phase. Again, we were giving PRT3789 weekly IV in combination with docetaxel, which is given either weekly or every 3 weeks per standard practice. We started at a dose of 120 milligrams of 3789 in combination with docetaxel, and are currently dose escalating at 3789 at 500 milligrams weekly with docetaxel. We're also planning to backfill cohorts during dose escalation. These are preliminary data, but from 11 patients, the median age was 65 years, more males than females, 1 prior line of systemic therapy. Most commonly we treated patients with advanced non-small cell lung cancer, followed by pancreatic cancer. There were more class 1 SMARCA4 mutations seen versus class 2 enrolled onto the trial. Here are the adverse events with the combination. In general, it's been well tolerated. There were no PRT3789 treatment-related SAEs. There was 1 patient who had a docetaxel treatment-related SAE. In terms of adverse events leading to any drug holds, there were no PRT3789 treatment-related adverse events leading to any drug holds. 3 patients had docetaxel adverse events that led to drug holds. 1 patient had an adverse event leading to dose reductions. There were no patients, however, who had any adverse events leading to treatment discontinuation. And importantly, there were no DLTs observed to date. The most frequent adverse events were really related to docetaxel and included fatigue, neutropenia, and diarrhea. Here are the pharmacokinetics available from 6 patients treated at the first dose level of 120 milligrams in combination with docetaxel. You can see here on the graph on the right that the PK in combination with docetaxel was very consistent with monotherapy given at 120 milligrams, suggesting no obvious drug-drug interactions. And promisingly, we are now seeing anti-tumor activity, which will be reported at a later conference. So to summarize, PRT3789 is a first-in-class novel targeted therapeutic designed to induce synthetic lethality in SMARCA4 deficient cancers while sparing normal tissue. Both monotherapy and in combination with docetaxel demonstrated an acceptable safety profile with no DLTs or study drug-related SAEs to date. Degradation of SMARCA2 was observed in PBMCs and tumor tissue, confirming target modulation. And proof of concept was demonstrated by multiple tumor responses and prolonged stable disease in patients with both non-small cell lung cancer and advanced esophageal cancer. Currently, monotherapy and combination dose escalation is ongoing, with the optimal RP2D still to be identified. A clinical trial testing the combination of 3789 plus pembrolizumab has initiated, and Prelude's also developing an oral selective SMARCA2 degrader to treat SMARCA4 deficient cancers. And a phase 1 study of PRT7732 in patients with SMARCA4 deficient solid tumors is currently underway. To end, I'd like to thank all of our study patients, their caregivers, investigators, coordinators, and healthcare staff at all of the study sites. I'd like to thank our study sponsor, Prelude Therapeutics, and of course our medical writing support team. Thank you very much.
Thank you very much. Are there questions in the audience? Tim, do you dare to make an idea where you have the feeling this drug is going? Can you help a bit how to think, or is it still too early and you need all the data before?
Thanks for that question. You know, we're still in dose escalation. As you can see, we're still pushing the dose. It's been very well tolerated, so I think there's still space to keep dose escalating right now. You know, on this trial, we really threw the net wide. We were learning about SMARCA4 alterations in cancer, and so, you know, it wasn't just class 1 alterations, which are truncations and deletions that we were actually recruiting, but we were also recruiting patients with variants of unknown significance with SMARCA4 mutations. So I think moving forward, you know, as we think about our backfill cohorts that we are currently recruiting to, you know, we're enrolling patients with measurable disease, with loss of function SMARCA4 mutations. I think in terms of line of sight, you know, the question is, can we develop this drug as monotherapy? And we are seeing monotherapy activity currently with this first-in-class agent that has indeed provided early proof of concept in the clinic. So I do think that there is certainly a proof of concept to actually take this line of sight as monotherapy in SMARCA4 loss of function alterations. As shown, you know, we're also exploring the combination with docetaxel. There's also a combination with pembrolizumab as well that's being initiated. So I think both monotherapy lines of sight and also different combinations, different rational combinations are still on the table. So that's how I would think about things. But really, it's about, number one, this has really shown proof of concept in terms of using a very selective way of targeting SMARCA2, which has been in the past an undruggable target. By using a degrader, we can really go after this target effectively and really show proof of concept in responses.
Thank you very much. This means that we will now continue with Elisa Fontana.